Hello everyone, I'm Dr. Rohan Khandelwal, your Marrow surgery faculty, and today I'll be talking about the FMGE January 2023 surgery recall. Now, I know the sentiment after the paper and especially paper 2. Paper 1 was in sync with how the FMG papers are usually asked, but paper 2 was quite tricky, lengthy, and there were questions which were asked from topics which haven't been asked previously. If I talk about surgery per se, there were at least 40 questions, and hardly 4 or 5 were previous year questions. Most of them were newly formulated questions, and I would say that some of these questions were good enough for any postgraduate exam and some even for the super specialty exams. So the standard is definitely being made tougher by the national board. Even last time surgery paper had some questions which weren't asked, which of topics which weren't asked previously, but this time they've taken it to a totally different level. Maybe this is transition towards next which is happening, but one thing is for sure that the clinical subjects, that is surgery, medicine, obs gynae, for FMG, now quick fix solutions will not work. You would need to study them in detail and you would need to understand the concepts, because these three subjects would cover almost 110 questions for you, and you really need to be very thorough with these three major subjects. Having said that, I've divided the questions topic wise so that you can have a look at them, and you can prepare for future FMG exams as well. So starting with the questions which are asked in general surgery, so which is not a component of the QSOFA score. Now QSOFA score has been asked previously. This is a question which has come in INICET many times and once in the FMG exam as well. Now QSOFA is quick sequential organ failure assessment score, and we know it includes altered mental status, systolic BP less than 100 and respiratory rate more than 22. What is not included is serum lactate is not included. This is not a part of the QSOFA score. This is the QSOFA score, the quick sequential organ failure assessment score, and you can see I've told you the parameters: hypertension less than 100, altered mental status, and tachypnea more than 22. Each value is given a score of 1, and if the score is 2 or more than 2, that is associated with a poor outcome. This was also a previous year question, a straightforward question which was asked. I asked you to identify the instrument, and this is a linear stapler. A linear stapler is used for resection and anastomosis of bowel, resection and anastomosis. One previously, this has also been asked for Zenker's diverticulum. It is also used for Zenker's diverticulectomy. We use a linear stapler. This one is a circular stapler, and circular staplers, the most common use of a circular stapler is stapler hemorrhoidopexy, which is the procedure of choice for hemorrhoids these days. So stapler hemorrhoidopexy, which is the procedure of choice for hemorrhoids, we use a circular stapler there. This is again a concept which has been asked many times in the FMG exam. They had shown an image of a patient with a split thickness skin graft being raised. Now, the most common donor site, is the thigh of the patient, and the graft is put on the same patient, right? So what kind of a graft would this be? This would be an autograft. Autograft is when you take some structure and you put it on the same patient. That is an autograft. Isograft has been asked many times. It is when grafts are exchanged between identical twins. Allograft is same species. So supposing you're taking the kidney from one individual and giving it to another individual, that classifies as an allograft. And a xenograft is from different species. You must have heard recently that a pig heart was transplanted in a human. So that classifies as a xenograft. So these definitions are a frequent part of the FMG exam, and you should be aware of them. This was an easy question. A soldier with injury to the leg develops extreme pain and crepitus at that site. Which of the following is the causative organism of gas gangrene? So they had given a history where they had said that a soldier sustains an injury, and there's extreme pain and crepitus. Crepitus would only form when there is gas. So some students were saying that they did not mention gas gangrene, they had just given this stem. So if they had given this stem just on the basis of extreme pain and crepitus, you can make the diagnosis of gas gangrene. Now gas gangrene, you know, occurs because of Clostridium perfringens. So this was a straightforward question. There were two questions from shock which were asked, and one of the questions is from hypovolemic shock, which is always asked in the exam. This one was a new question where they had asked which of the following is seen in all types of shocks. You know, there are various types of shocks. You have hypovolemic, cardiogenic, distributive, septic shock. But one common theme amongst all shocks is that the tissue is receiving less oxygen, right? That is a common theme around all shocks. And what we were taught in physiology is that shock is hypoxia at the cellular level. So the common theme is going to be decrease in tissue perfusion. That is what is seen in all types of shocks. A patient is brought to the emergency room after road traffic accident and vitals point towards shock. The urine output is decreased. Patient appears to be confused, right? From which stage of shock does urine output start reducing? Now this was a tricky question. This was based on this table which is there of hypovolemic shock, which I've highlighted umpteen number of times that there is invariably a question which is asked from this table. And you know there are 4 classes of hypovolemic shock. Class 1 is when the percentage of blood volume loss is 0 to 15%. There is no change in the vitals here. Class 2 is when the heart rate is increased, there is tachycardia, but this is compensated shock. And urine output can start reducing here. Okay. Can start reducing, but the systolic BP remains normal. That is why we call it compensated, because despite the blood loss of 15 to 30%, the systolic BP remains normal. Class 3 is when the systolic BP starts to fall. This is 30 to 40%. Of course, there will be decreased urine output here as well. And class 4 is when the vitals are not palpable. I mean, the pulse is not palpable, the BP is not recordable, the vitals are not recordable. So these are the 4 classes of shock. The question here was, from which class does urine output start to reduce? So it starts to reduce from class 2, which is going to be moderate shock. So moving on to the questions pertaining from breast, thyroid, head and neck and endocrine system. There were at least 7 or 8 questions from these topics. Breast is usually asked quite a lot in FMGE exam, and this time also there were 4 questions, although the difficulty of 2 questions was quite high. And one of the questions was recently asked in the super specialty exam as well. So that was the level of questions which was being asked. So most important risk factor for acute mastitis. We know breast abscess is a very common topic which is asked in the FMG exam, and the harbinger of breast abscess is a cracked nipple, and through that cracked nipple, Staph aureus, which is the most common organism, that enters the breast and causes the infection. So cracked nipple is the cause of acute mastitis. This was a repeat question. Peau d'orange or orange peel appearance has been asked many times in the exam, and they had asked what is the cause of the condition which is shown. So it was an image of peau d'orange. To confuse students, they had given superficial lymphatics and deep lymphatics. Now we know that peau d'orange occurs because of the involvement of subdermal lymphatics. So subdermal lymphatics are superficial lymphatics which is going to give rise to PD or peau d'orange appearance, and this includes involvement of the skin. Dimpling is another sign which is because of ligaments of Cooper involvement. Retraction of the nipple is because of lactiferous ducts. It can be circumferential, which is usually seen in cancer, or slit-like, which is seen in ductictasia. Peau d'orange is orange peel appearance due to subdermal lymphatics. Now, this was the question which was asked in one of the recent super specialty exams. Mutation in BRCA gene should be checked in which of the following patients except. Now, patients who have male breast cancer, bilateral breast cancer, breast or ovarian cancer, or they have a strong family history of breast and ovarian cancer, or if the patient is less than 40 to 45 years of age, that means a young patient with breast cancer, those are the patients where we check for BRCA mutations. So the exception here is a patient who is more than 50. That is not the correct answer. So if you look at the indications, right, you will have a BRCA mutation already in a first degree relative. If you have bilateral breast cancer, triple negative breast cancer, male breast cancer, or if there is early young patient with breast cancer, that means breast cancer less than 45 to 50 years of age, that is when we check for BRCA mutation. We don't check it in all the patients. This was also a tricky question. We know that staging of breast cancer is usually asked in the exam. Breast and oral cancers are the two stagings which are frequently asked in the FMGE exam. But the twist were the prefixes which they had used. So you had a 51-year-old female who was complaining of a mass in the right breast. The mass was ulcerated, ulceration was shown, discharge was shown, and the mass was more than 2 centimeters and lymph nodes were present. The mass was not fixed to the skin. Now this is something which the students have said, but if ulceration was there, I think so this statement wouldn't have been there. Okay. Now they are asking the stage. So we know this prefix of C means clinical staging. That means when we examine the patient and then we conclude the staging, that is known as clinical staging, and we write C, T, whatever, N, whatever, and M, whatever. Here, because the skin is involved, we know it is T4. We know it is T4, and T4B is involvement of skin. If PDO, peau d'orange, is present in more than 1/3 of the breast, then it would be T4D or inflammatory cancer. Okay. N1 because the lymph nodes are enlarged, and M0 because no mets are present. So this was the correct answer, CT4N1M0. Now what does Y mean? Y, I have told you, if you've seen my videos, I've told you why we write when the staging is done after neoadjuvant therapy. If we do the staging after neoadjuvant therapy, that is when we write it as YTNM. Okay, so supposing the patient has received some form of chemotherapy or hormonal therapy and then we do the staging, then we will write it as Y staging, YT3N1 or YT2N1. Here nothing of that sort was mentioned. That is why Y options got eliminated, and because ulceration was there, it was easy for you to mark. So if you knew this concept of C and Y, it was an easy question. Otherwise, a tricky question for the FMG exam. Moving on to the questions regarding thyroid, parathyroid and endocrine system. There was a patient in which recurrent kidney stones and psychiatric symptoms with fatigue was present. Which investigation will be used for the diagnosis? And they had shown an X-ray of the hand which was showing features of hyperparathyroidism. Now, hyperparathyroidism, you know the clinical features are bone stones and abdominal groans. That is the mnemonic: bone stones, abdominal groans. In bones, you can have brown tumors, you can have subperiosteal bone resorption, more on the radial aspect, salt and pepper skull, right? So you can see subperiosteal bone resorption, you can see these brown tumors, and you can even see salt and pepper skull. So these are the bony findings. You can get multiple or recurrent renal stones, which is the most common finding. There can be abdominal pain due to pancreatitis as well, and there can be psychiatric symptoms. So when the patient is showing features of hyperparathyroidism, of course we will do serum PTH to see if PTH is raised or not. Okay, PTH should be raised here. But to see whether this is due to an adenoma or it is due to hyperplasia, we will do a sestami B scan. A technetium 99 sestami B scan will be carried out in this patient to differentiate whether it is an adenoma which is causing it or it is hyperplasia which is causing it. So the correct answer is going to be a technetium 99 sestami B scan. This was asked previously as well. This sestami B scan has been asked in your exam. A 32-year-old male patient comes with episodic hypertension, headache, sweating and palpitations. What is the most likely diagnosis? Even in these potential question videos which I had shown, I told you that either carcinoid or pheochromocytoma is always asked. This was the question stem for pheochromocytoma, where you know episodic hypertension, headache, sweating, these are the features. In a young patient, if the patient is coming with these are features of pheochromocytoma. And to confirm pheochromocytoma, we will do plasma-free metanephrines. That will be the test to confirm the diagnosis. Screening test is 24-hour urinary VMA. That is the screening test. So 24-hour urinary VMA is the screening test, whereas plasma-free metanephrines will be the diagnostic test which will tell us the diagnosis of pheochromocytoma. For carcinoid tumors, we are going to do urinary 5-hydroxy-indole acetic acid. Okay, that is what we are going to do for carcinoid tumors, which is not a superior mediastinal tumor. So mediastinal tumors, superior mediastinum, thyroid can be there, thymus can be there, right? We know that thymomas are the most common mediastinal tumors overall. Okay, parathyroid tumors can also be there in the superior mediastinum. Leukemias are not seen. Sometimes lymphomas can be seen, but not leukemias. Okay, and if lymphoma was there in the option, then also you would mark that because it is uncommon in the superior mediastinum. Lymphomas are usually seen either in the anterior or the posterior mediastinum. You should also know the most common mediastinal tumor in children. The most common mediastinal tumor in children is a neurogenic tumor, and this is usually seen in the posterior mediastinum. A 50-year-old male with a history of tobacco chewing presents with a whitish lesion over the buccal mucosa since 6 months. So there is a history of tobacco chewing, there is a whitish lesion. We know these whitish lesions are known as leukoplakia. Now, if you have a leukoplakic patch in a patient who is a tobacco chewer, it has been persisting for 6 months, we will always do a biopsy to rule out cancer in that condition. Because we know that leukoplakia is a pre-malignant condition which can get converted into cancer. So what will be the next step in the management? Of course, you will ask the patient to avoid smoking, but we don't do wait and watch. We will do a local excision and biopsy to rule out cancer in these patients as well. They had given one of the options was steroid injection. Steroid injection is not used in leukoplakia. It is used in a condition known as chronic submucous fibrosis, which can also occur in patients who are tobacco chewers. And this is the one which can also increase the risk of cancer. But in those patients, we use local triamcinolone injections. A 50-year-old lady is diagnosed with papillary thyroid cancer and undergoes thyroidectomy. So papillary thyroid cancer we know is the most common thyroid cancer. The patient has undergone a thyroidectomy and she comes to you for second opinion after the procedure. What would you recommend? So if you remember the treatment of thyroid cancers, we have discussed that differentiated thyroid cancers, once the surgery has been done, we will do a radioiodine scan. And why are we doing the radioiodine scan? We are doing it to look for residual disease or for metastatic disease. So if you see the flow chart, once the surgery has been done, then we wait for 4 to 6 weeks and we will do a whole body iodine scan. This whole body iodine scan tells us about residual disease or metastasis. And if residual disease or metastasis is present, then we will carry out radioiodine ablation, which is iodine 131. And another question which has been asked is that the half-life is 8 days and this acts via beta rays. So that is what you should know regarding the follow-up in a patient with papillary thyroid cancer after surgery. These were the questions regarding head and neck, thyroid and endocrine system. Moving on to the questions from GIT. So which of the following components are correct components of child PUG score? Now child PUG score is an important score and they had given various options which had various permutations. The correct answer here, child PUG score, has 5 things: albumin, bilirubin, PTINR, ascites and encephalopathy. These are the 5 things which are included in the child PUG score and you need to know this for future exams as well. So child PUG score, encephalopathy, ascites, bilirubin, albumin and prothrombin time or INR. Each value is given a score from 1 to 3. So the minimum score is 5 and the maximum score is 15. If it is child PUG A, that is 5 to 6, that means least severe liver disease and you have adequate functioning liver present. B is moderate 7 to 9 and C is severe 10 to 15, where remnant liver tissue or functional liver tissue is hardly present, and that is decompensated liver disease. A 32-year-old patient undergoes an emergency laparotomy for perforation. So they've mentioned that it is an emergency laparotomy for perforation, right? So after this they are asking which is the sure shot sign for wound dehiscence. Now if you remember your lecture on general surgery, the causes of postoperative fever, I have told you on postoperative day 6 usually there can be a burst abdomen. The rectus sheath can open up and that is known as burst abdomen or abdominal wound dehiscence. Now abdominal wound dehiscence, how do we know wound dehiscence has occurred? There will be copious serosanguinous discharge. This is also known as Salmon fluid sign or serous fluid sign. Large quantities of reddish fluid is going to come out and that tells us that the rectus sheath has opened up and the bowel is coming out of the wound. That is abdominal wound dehiscence, and in such a situation the emergency management is urobag laparotomy. Which of the following structures causes constriction of the esophagus at 25 centimeters from the incisors? Again, this was a straightforward simple question. We know that there are 3 constrictions and whenever we do upper GI endoscopy, we measure these constrictions from the upper incisor. The constrictions are at 15, 25 and 40 centimeters. 15 centimeters is at the level of C6, which is the pharyngoesophageal junction. And this is the narrowest portion of GIT. 25 centimeters is the left main stem bronchus or the arch of aorta, and 40 centimeters is the diaphragm. So the correct answer here is going to be aorta or left main stem bronchus. That will be the correct answer to this question. There was another question which was asked here. This is a previous year question which has been asked, where a child was brought to the emergency after ingestion of a coin. Which of the following interventions would be used in the management of this patient? So they are saying that the child has ingested the coin. They have not mentioned that the child is breathless, is coughing, is choking. They have not mentioned anything of that sort. Also, they had shared a front on view and they had shared a lateral view as well, which showed that the coin was there in the esophagus. If the coin is in the esophagus and the lateral view, you can very well make out that esophagus is going to be posterior, trachea is anterior. So you can see a gas shadow in front of the coin. So if the coin is in the esophagus, I just told you C6 is the narrowest portion. In that case, we need to carry out an esophagoscopy to remove the stone. That is what we need to carry out. Bronchoscopy is not required. Tracheostomy is not required. Heimlich's is also not required for esophageal foreign bodies. It is required if the foreign body is lodged in the respiratory passage. A patient presented to the surgery OPD with complaints of pus discharge per annum. Patient was diagnosed to have a fistula in ano. So up till recently, they usually used to ask one image-based question from rectal and anal disorders. Okay. Now they've asked the gold standard investigation. They've told you the diagnosis is a fistula. What is the gold standard investigation? The gold standard investigation is an MR fistulogram, MRI. And to confuse students, they had also given a fistulogram, and a lot of students got confused and marked that. But you should know that MRI is the investigation of choice for perianal fistulae, and there is a Parkes classification for perianal fistulae, the most common being the intersphincteric type. Which of the following procedure has maximum risk of recurrence in a duodenal ulcer? Now, questions regarding vagotomy have not been asked for many years, neither in the PG exams nor in the SS exams, and surely not in the FMGE exam. So this was a surprise question which was asked after a long time. Up till last time, they were mainly asking questions pertaining to complications following gastrectomy or gastric reconstructions. This time they have asked regarding vagotomy. So vagotomy is a surgery which is done to reduce the acid load, and once that is done, it helps in the healing of an ulcer. So highly selective vagotomy has maximum recurrence, but least side effects. It has least side effects or least vagotomy related complications. Truncal vagotomy, on the other hand, has least recurrence rate, because maximum acid reduction occurs there, but it has maximum vagotomy related side effects. Okay, so this is all you need to remember regarding vagotomy, and you also need to remember that these days usually we don't do vagotomies, we just give proton pump inhibitors. So here they were asking maximum risk, you are going to mark highly selective vagotomy. A homosexual man complains of painful defecation and a mass protruding from the anal canal. On biopsy, diagnosis of squamous cell carcinoma of the anal canal is made. So homosexual man, human papilloma virus, all these are risk factors for squamous cell carcinoma of the anal canal. This question was quite frequent in the PG exams and the FMG exams a few years back. So it's made a comeback after a gap of a few years. And the treatment for squamous cell carcinoma of the anal canal is known as Nigro's regime, which is combined chemoradiation. So you're going to give chemotherapy and you will give radiotherapy as well. Chemotherapy is usually 5-fluorouracil and mitomycin C, and radiotherapy is also used. So this combined chemoradiation for anal cancers is known as Nigro's regime. Endocrine tumors of the pancreas was asked last time also, this time also, they just keep on changing. Last time they asked about, they had asked about a gastrinoma, this time they've asked about a glucagonoma. So you had a diabetic patient with DVT and a necrolytic migratory rash. Okay, so diabetes, dementia, DVT and a rash, these are classical features of a glucagonoma. Okay. So insulinoma is the most common pancreatic endocrine neoplasm, equally distributed. 90% patients have benign tumors, and the patient comes with Whipple's triad, that is fasting hypoglycemia, sugar less than 40 and rapid resolution on giving glucose. The gold standard test here is 72-hour fasting test. Gastrinomas, they arise from the G cells, also known as Zollinger-Ellison syndrome. 70 to 80% are malignant, and most of the gastrinomas arise from the gastrinoma triangle. This has also been asked in the exam. The gastrinoma triangle or the Passerose triangle is formed at the junction of the cystic duct with the CBD, second part with third part of duodenum, and junction of head and neck with the body of pancreas. Majority of the gastrinomas lie within this triangle and mostly arise from the wall of D1. Glucagonoma, 4Ds, diabetes, dermatitis, DVT and depression, and you get a classical necrolytic migratory rash as was asked in the question. Idiopathic hypertrophic pyloric stenosis or congenital hypertrophic pyloric stenosis is a constant question in all the exams, and this was no surprise that it was asked in the FMG exam as well. They had asked which is not true regarding idiopathic hypertrophic pyloric stenosis. Presents with non-bilious vomiting. This is true because the hypertrophy or the obstruction is before the duodenum, so it does present with non-bilious vomiting. It is caused not by hypertrophy of the longitudinal muscle, it is caused by hypertrophy of the circular muscle. That is what leads to idiopathic hypertrophic pyloric stenosis. Ultrasound is very sensitive. Yes, thickness of more than 4 millimeters and the length of the pyloric channel more than 16 millimeters is quite sensitive in diagnosing this condition. And hypokalemic, hypochloremic metabolic alkalosis with paradoxical aciduria is seen in this condition. This has also been asked many times. So this was a straightforward question. We know the investigation of choice is ultrasound, thickness more than 4 millimeters, length more than 16. You can get a single bubble sign, and if you do a contrast study, you can get string sign, double track sign, or mushroom sign. Males are more commonly affected. Patient comes with non-bilious vomiting. There is visible peristalsis from left to right, and the best time to examine the patient is during feeding. The management, we know that first we have to correct the dehydration, give fluids to these patients, and we either use 0.45% normal saline or ringer lactate, and the surgery carried out is Ramsted's pyloromyotomy. Again, a straightforward question. An alcoholic patient presents with epigastric pain radiating to the back. Amylase is raised. What is the diagnosis? So it's straightforward. It is pancreatitis. Most common indication for splenectomy is ITP, idiopathic thrombocytopenic purpura. In these patients, there are autoantibodies, platelet counts are low, and splenectomy is usually done to boost the platelet counts. So this is the most common indication for splenectomy, which you should know about. Of course, if trauma is also mentioned, then you will mark trauma as the answer. But here trauma was not there, so ITP will be the correct answer. There were two questions regarding hernias. They were reasonably easy questions. A patient presented to the surgery OPD with a reducible mass in the left inguinal region. Cuff impulse was present. So they've said cuff impulse is present and a diagnosis of inguinal hernia was made. Some students were saying that it was indirect inguinal hernia which was given there. Irrespective whether it is indirect or direct, they had asked the surgical management, and we know that the best surgical management for hernias is hernioplasty, not herniatomy. Herniatomy is done in children, and when there are congenital hernias, that's when we do herniatomy. Hernioplasty is when we are using a mesh, and that is the treatment of choice. We carry out a Lichtenstein's tension-free mesh hernioplasty. This one was a slightly tricky question. Which of the following structure of pelvis will have recurrent hernia? The answer is short and wide. Question which has not been asked in any previous exam, and difficult to get the reference as well. But short and wide would be the best option to go for. Those were the questions regarding GIT. Urology also, there were around 6 or 7 questions, same number for vascular surgery as well. Fournier's gangrene was asked. This is pretty straightforward. It has been asked many times previously as well. Which of the following is not true regarding the condition shown in the image? They had shown gangrene in the area of the perineum. This you know is known as Fournier's gangrene. This is Fournier's gangrene, which is necrotizing fasciitis involving the perineal region. So testes are preserved. Yes, this is a correct statement. Because of dual blood supply, testes are usually preserved. It is common in diabetic patients. There is high mortality. Staph aureus is the causative organism. This is false. It is a synergistic infection. Synergistic infection means that both aerobic plus anaerobic bacteria are involved in this condition, and the mainstay of management is aggressive debridement. You have to cut the dead tissue. That is one of the mainstays of treatment. What is the initial management of a patient with benign prostatic hypertrophy with urinary symptoms? So any patient who comes with features of prostate enlargement and is diagnosed with BPH, initially we start with medical management, and the option given was prazosin, which is an alpha blocker. Medical management, alpha blockers are fast acting. 5-alpha reductase inhibitors can also be used. They are slow acting, but they have a more sustained effect. The example of 5-alpha reductase inhibitors is finasteride or dutasteride. Usually we use a combination therapy to start with, where we start an alpha blocker and a 5-alpha reductase inhibitor together. Surgical management, if it has to be done, we usually do a TURP, or these days lasers are also being used. The most common laser is ND-YAG. The best laser is KTPA, green light laser. Which of the following, all of the following are true regarding nephroblastoma? So this was a question regarding Wilms tumor. It was very surprising. There was one question regarding Wilms tumor, and there was one question regarding renal cell carcinoma, also bladder carcinoma. So one of the themes in this time's exam, lots of questions regarding cancers and their management. So up till previously in the FMGE exam, such in-depth management of cancers was not being asked. So, definitely they are raising the standards, and you need to have more in-depth knowledge of surgery to answer these questions. So if you've seen the Marrow videos, all this is covered, but from the FMG perspective, everyone was being very selective because they were mostly asking those topics. This time, of course, they've bowled a googly or a bouncer, and many more topics and tough questions have been added. All of the following are true regarding Wilms tumor except hematogenous spread is correct. That is why lung metastasis, it is the most common site of metastasis. Treatment is chemotherapy followed by surgery. This is also true. There are two ways to proceed in Wilms tumor. You either do surgery first followed by chemo, or you do chemo followed by surgery. And one main difference between Wilms and renal cell cancer is that Wilms is chemosensitive, whereas renal cell cancer is not chemosensitive. It is chemo and radio resistant. RCC is chemo and radio resistant. It is the most common intra-abdominal malignancy in children. This is wrong. Most common pediatric renal malignancy. It is the second most common abdominal malignancy in children, most common being neuroblastoma. Patient comes with a mass and hematuria. There are 3 syndromes which can be associated with Wilms tumors. You have Beckwith-Wiedemann, Denish-Drash, or Vagar syndrome. There are 2 stagings. You don't need to know the stagings in detail. National Wilms tumor staging or the Society of International Pediatric Oncologists. Just one thing which is unique in Wilms tumor staging, there is a stage 5 which you will not see in other tumors. Stage 5 is bilateral Wilms tumors. So this was another question from urology. A 44-year-old female with a flank mass which is ballotable. We know renal masses are ballotable, kidney masses are ballotable, and the mass measures 4 centimeters on a CT scan. Urine shows malignant cells. What is the management? So you have malignant cells in the urine and mass is 4 centimeters. So we are dealing with a patient with renal cell cancer. We know T1 is less than equal to 7 centimeters. Okay. And for T1 tumors, we can do partial nephrectomy. We don't need to do radical nephrectomy. If it is beyond T1, if it is T2, T3, T4, then we will think about doing radical nephrectomy. But for T1, we can do partial nephrectomy or nephron sparing surgery. That will be the correct answer. So very simple, T1 less than 7 centimeters. Or if it is a bilateral renal cell cancer, then we do partial nephrectomy, otherwise radical nephrectomy. 55-year-old male is diagnosed with left testicular carcinoma. Which of the following lymph nodes is the first to be involved? The option number A they had given was inguinal, and this was to confuse students. This we've discussed many times that testicular cancers, they don't go to the inguinal lymph nodes first, they go to the para-aortic lymph nodes. right? Because that is where the testis develops and then it comes down into the scrotum. So the first echelon or the first draining lymph nodes are the para-aortic lymph nodes. Now again, they had made it very tricky. You need to know that from left testis, the first drainage site is to the para-aortic lymph nodes, which is the correct answer. But if right testis was asked, then it would have been inter-aortocaval, means between the aorta and the IVC. So these are lymph nodes around between the aorta and the IVC, whereas left testis goes to lymph nodes which are around the aorta, para-aortic lymph nodes. So this you should be aware of. Which of the following will not have bilateral hydronephrosis? We know hydronephrosis is dilatation of the pelvic-calyceal system, that is known as hydronephrosis. Now, if you remember the lectures, I've told you that any cause which occurs before the opening of both the ureters will lead to unilateral. So anything which goes wrong here, here or here will give rise to unilateral. But any cause which occurs after both the ureters have opened up, that will cause bilateral hydronephrosis. So anything here, here, here will cause hydronephrosis on both the sides. Now let's see. Phimosis means there's inability to retract the foreskin. So that will give rise to bilateral hydronephrosis. Okay, that is going to give rise to bilateral because it is distal to the opening of both the ureters. Similarly, posterior urethral valve also bilateral hydronephrosis. Urethral stricture also bilateral hydronephrosis. Retrocaval ureter is only seen on the right side. Retrocaval ureter means that the right sided ureter goes behind the IVC. That is retrocaval ureter. So the correct answer is retrocaval ureter, which will give rise to unilateral hydronephrosis. There was another question regarding ureterocele or cobra head or adder head appearance. This is a previous year question which has been asked many times in the exam. This is a retrocaval ureter only on the right side, and you get a reverse J or fish hook sign. That is the sign which you will see. Posterior urethral valves, bilateral hydronephrosis, and you will get a keyhole defect. You get a keyhole defect on micturating cystourethrogram, or on ultrasound you get a keyhole defect. There was another question regarding ureteric stones. They had shown an X-ray KUB. KUB is kidney urinary bladder. X-ray they had shown, and they had shown stones in the ureter, and they had asked how do we manage stones in the ureter. ESWL is extracorporeal shock wave lithotripsy. This is done for stones which are there in the kidney. PCNL is percutaneous nephrolithotomy, again done for stones which are there in the kidney. Wait and watch is for stones which are less than equal to 5 millimeters in size. They had not mentioned the size, so the correct answer will be URS. URS is ureteroscopic removal of stones. Is ureteroscopic removal of stones. That means you put a scope in the ureter and then you go and catch the stone. So ureteroscopic removal of stone is the correct answer. URS is what is done for ureteric stones. This was a straightforward question. They had shown a CT of a patient with an abdominal mass, and you could see that the kidney was fused, the lower end. This is horseshoe kidney. Horseshoe kidney is when the lower end is fused and the ascent is restricted by the inferior mesenteric arteries. The fused portion usually lies at the level of L3. Adrenals are in the normal position, and we never cut the fused portion. On intravenous urogram, you will get a flower vase sign or a handshake sign, and the patient usually comes with an abdominal lump. So like I said, there was a question regarding testicular cancer, bladder cancer, renal cancer, Wilms tumor. So 4 cancer questions just from urology they had asked, which was quite surprising. A 70-year-old male presents with painless hematuria. He is diagnosed to have bladder cancer invading the muscle layer. What is the management? So we know bladder cancer can be divided into superficial bladder cancer. Superficial bladder cancer is above the muscle layer, and if it is above the muscle layer, we will do TURBT. TURBT is transurethral resection of bladder tumor. TURBT, transurethral resection of bladder tumor. Plus we will do either intravesical chemo, means we are going to give chemo inside the bladder, or intravesical immunotherapy in the form of BCG. Yes, BCG, which is the tuberculosis vaccine. But this is for superficial bladder cancer. So that is why these two options were out. Now, advanced bladder cancer is when the muscle layer is invaded. When the muscle layer is invaded, we either have to do a partial cystectomy or a radical cystectomy. And when we do a radical cystectomy, the prostate is also removed. Now, because the option of partial cystectomy was not there, the correct answer here is going to be cystoprostatectomy, or in other words, a radical cystectomy. So these were the questions regarding urology. Moving on to vascular system, there were 4 or 5 questions from vascular system also. Which of the following is the gold standard in the management of varicose veins? So these days, varicose veins, gold standard for varicose veins, we are using either RFA, which is radio frequency ablation, or we do EVLT, which is endovenous laser therapy. These are the 2 surgical options which are the gold standard for varicose veins. They had given radio frequency ablation, and that is the correct answer. Some students said that radio frequency ablation was not given. The term thermal ablation was given, which is also the correct answer, because thermal ablation includes both radio frequency and laser ablation. Sepsis, subfacial endoscopic perforator surgery, we usually are not doing this. Stripping and ligation is usually out these days. So the best treatment is radiofrequency ablation or EVLT. Again, this time I guess questions were they were framed in a tricky manner. They have asked previously about grafts for coronary artery bypass grafting, CABG's coronary artery bypass grafting. Now they were asking least commonly used graft. So we know left internal mammary artery, LIMA, is for left anterior descending artery. LIMA LAD, that's how you remember it. Left internal mammary artery graft is the best for left anterior descending artery. The great saphenous vein is the most commonly used graft. Radial artery graft is also used. Intercostal artery graft is the least common. So that is the correct answer, intercostal artery. I would say it was a tricky question. If you knew these two, you could have eliminated, but it was a tricky question which was asked. Next was a patient presented with severe abdominal pain radiating to the back with nausea. CT was done and the image is shown below. What is the next step in the management? So this was a classical CT where you could see a split in the aorta. This is aortic dissection. This is aortic dissection, and in aortic dissection patient has pain which radiates to the back or the interscapular region. Most common site is the lateral wall of the ascending thoracic aorta. It can proceed on to the abdominal aorta as well. Patient comes with chest pain radiating to the back, more common in males. In stable patients, we do a CT angio, CT film was shown. Unstable patient, we do a transesophageal echo. X-ray shows widening of the mediastinum. You can see widening of the mediastinum here. CT I've already shown you. It shows an altered lumen in the aorta. There is a DeBakey's and a Stanford classification. DeBakey type 1 is the most common. Type 1 is ascending and descending. Type 2 is only ascending and type 3 is only descending. So the management is, because hypertension is the one which triggers this tear. Hypertension is the one which leads to this tear. So we have to control the BP by giving esmolol, or here they had given some students said that the option which was given was nicardipine. They had given nicardipine and surgery, only nicardipine, wait and watch. So we have to control the blood pressure. Nicardipine will be. So the correct answer here is going to be, you have to reduce the BP using nicardipine if that was there, or if esmolol, whatever the option which was there, followed by a graft repair, a Dacron graft repair. That is the treatment which we have to carry out. There was another question regarding a 79-year-old chronic smoker with coronary artery disease who presents with foot pain. The image of the foot with blackening of toes was shown. Now, here it was tricky because a lot of students read chronic smoker and they marked Berger's disease. But two things which you failed to analyze was the age, which was 79, and the history of coronary artery disease. Considering these two, the answer is going to be atherosclerosis, and you need to know that smoking is also a risk factor for atherosclerosis. Yes, it is a risk factor for Berger's, but it is also a risk factor for atherosclerosis. So you need to know Berger's and atherosclerosis. Berger's is also known as thromboangiitis obliterans, more common in males, usually third decade. Lower limbs are more commonly involved, and smoking is a major risk factor. Atherosclerosis, on the other hand, males and females are equally affected, mostly seen after the fifth decade of life. Again, the lower limb is more frequently affected, and arteries are more commonly involved. In atherosclerosis, the larger vessels are involved and proximal to distal spread is there, whereas in Berger's it is the opposite, it is distal to proximal. But in this question, the two things which clearly point towards atherosclerosis is the age and the history of coronary artery disease. These were the questions from vascular surgery. From trauma and burns, this time there were just 3 questions. Two questions are related to head injury, and one was basics of general trauma. So this was a repeat question. A 32-year-old lady sustains a fall from a flight of stairs and is brought to the ER in an unconscious state. NCCT is done. So NCCT, you can see a biconvex or a lens-shaped hemorrhage. This is extradural hemorrhage. That was the correct answer. Straightforward question. Contusion is when you have intraparenchymal hemorrhage. Extradural hemorrhage is when you get a biconvex hemorrhage or lens-shaped hemorrhage, that is extradural, usually seen in young patients. And another question which has been asked is that the middle meningeal artery is involved. The middle meningeal artery is involved here. This is the site, the pterion, which is the most common site where this occurs. Subdural hemorrhage is usually seen in elderly patients, and this is following a trivial trauma, and here we will get a concavo-convex hemorrhage. We get a concavo-convex or a crysenteric hemorrhage in subdural hemorrhage. Another previous year question which was asked, this was asked last time as well, a very straightforward question. A 50-year-old lady complains of worst headache of life. She has not experienced this kind of headache in the past. What is the most likely cause? It is subarachnoid hemorrhage. So subarachnoid hemorrhage gives rise to thunderclap headache or worst headache of the life. This is usually due to a rupture of the berry aneurysm, which can be triggered due to hypertension. This was the repeat question. Now the previous one, this was the repeat question. A child is brought to the ER with diarrhea. During assessment, ABCDE is evaluated. What does D stand for? You know, A is for airway, B is for breathing, C is for circulation, D is for disability, and E is for exposure. So D stands for disability. That is the correct answer. So these are the approximately 38 to 40 questions which were asked in surgery. I've told you the distribution, and my brief analysis for this is going to be that they are gradually migrating towards next. So the difficulty of questions in the clinical subjects, especially surgery, obs, gynae, medicine, is going to be high. So you need in-depth knowledge of these 3 subjects, because these 3 subjects make up at least 120 to 130 questions. So please be thorough, no shortcuts in the clinical subjects at least. if you do that, if you prepare your clinical subjects well, you will have an excellent chance of scoring a high score in the FMG exam. If you have any further doubts, you can always ask me on my Instagram ID, that is left-handed surgeon. I wish you all the best for your preparation and for the result. Thank you.